Hello and welcome to the video. Today I'm going to be talking about understanding hyponatraemia in terms of the underlying pathophysiology and the clinical application. So without further ado, let's get right into it. Sodium is an important electrolyte in human blood that is present at the highest relative concentration and plays an important role in a number of physiological processes. Namely, the sodium-potassium ATPase is able to generate a sodium gradient, from which the sodium ions are used for important processes such as co-transport and facilitating depolarization in the context of neuronal transmission and cardiac contraction. Because of the significant concentration of sodium in the blood, it is osmotically active, which means relatively higher amounts of extracellular sodium will lead to more intracellular water going towards the extracellular space to equilibrate the intra and extracellular concentrations, and vice versa. The amount of intravascular sodium is therefore intrinsically linked to the amount of intravascular volume, and so to prevent fluid shifts, the body must be able to maintain a stable sodium concentration by maintaining a stable intravascular volume. The body is able to do this through this amazing mechanism known as the renin-angiotensin-aldosterone system, which is shown in this diagram here, and explained in more detail in another video, which I've provided a link here. But briefly, this diagram basically shows the blood circulation throughout the body, from the heart all the way to the kidney and back to the heart again. When the patient is dehydrated with relatively low intravascular volume, there's reduced perfusion of blood to the kidney, which leads to the activation of this renin-angiotensin-aldosterone system, which ultimately leads to physiological changes which results in reduced urine output and therefore a conservation of intravascular volume by increasing renal sodium reabsorption, which in turn increases water reabsorption at the level of the kidneys. Water reabsorption is mediated by a hormone known as ADH or antidiuretic hormone, and this process of water reabsorption is discussed in more detail in a previous video, which I've attached a link to here. So ultimately, when this RAAS system is working, we're able to maintain our intravascular volume and maintain our sodium concentration in the blood. Now, hyponatraemia is when there is a relatively low sodium concentration, and this is due to either a direct problem with the renin-angiotensin-aldosterone system or the antidiuretic hormone system, or it is due to a pathological process which exceeds the capacity of these normal compensatory mechanisms to maintain a normal sodium concentration, thus leading to hyponatraemia. The other important background point I'd like to make is that if we go back to basic chemistry, we know that the concentration of a solute is dependent on N over V, or the number of moles of the solute divided by the volume of the solvent. Therefore, the blood concentration of sodium is dependent on the number of moles of sodium contained within the blood divided by the intravascular volume. And so, to get a hyponatraemia, you must have relatively less sodium compared to intravascular volume than would be considered normal. Now, there are three scenarios where this can occur. Firstly, you can have relatively less volume but even less sodium, which therefore leads to hypovolemic hyponatraemia. In a hypovolemic state, the renin-angiotensin-aldosterone system should be hyperactivated, and so to get a hypovolemic hyponatraemia, there must be excess renal sodium losses due to a faulty renin-angiotensin-aldosterone system, or intrinsic losses due to renal pathology, or the renin-angiotensin-aldosterone system is normally activated but the extra-renal losses exceed the capabilities of the renin-angiotensin-aldosterone system from retaining sodium and intravascular water. The second way you can get hyponatraemia is when you have a relatively normal amount of sodium in the blood, but a relatively increased intravascular volume compared to normal. And this is often due to inappropriately elevated levels of antidiuretic hormone, which therefore lead to more water reabsorption than is required and expected. which ultimately dilutes the sodium and leads to hyponatremia. And this is called euvolemic hyponatremia. And thirdly, you can get an increase in the amount of sodium in the blood, but a relatively greater increase in the amount of intravascular volume in something called hypervolemic hyponatremia. This is due to chronic pathological hyperactivation of the renin-angiotensin-aldosterone system and is seen in chronic heart failure, liver failure, and kidney failure. This process is also explained in a previous video, which I've put a link to here. So now that we have this background understanding, we can go on to talk about an approach to hyponatremia and go into more detail about these three subtypes of hyponatremia and their underlying etiologies. So the first thing to do is to determine if the patient needs acute treatment with hypertonic saline. This is usually only reserved for patients with severe symptomatic hyponatremia who presents with things like confusion, seizures, possibly even a coma. These patients will need to be admitted to a HDU or an ICU to have their sodium replaced in a closely monitored environment. In the vast majority of cases where the hyponatremia is asymptomatic, we firstly need to determine if the hyponatremia is a true hypoosmolar hyponatremia or if it is a pseudohyponatraemia or osmotic hyponatremia which does not need intensive investigation or further management. Osmotic hyponatremia is an entity where you get a hyponatremia due to the presence of an excess amount of osmotically active components of the blood. The osmolality can be estimated using the calculation of 2 times the sodium plus urea plus the glucose concentration of the blood. And this is because these components are present in significant concentrations and therefore contribute significantly to the osmolality. The osmolality of blood is usually around 290 or within a reference range of about 280 to 300 milliosmoles per kilogram or millimoles per kilogram. Using this formula to calculate the osmolality and concentrations in millimoles per liter, you can see that we do get a value of about 290 using typical values. So for example, if sodium was 140, 2 times 140 is 280, plus let's say a urea of 5 and a glucose of 5, which makes 290. This is important because in certain states you can have very high ureas, such as in renal failure, or very high glucose, such as in diabetic ketoacidosis or hyperglycemic hyperosmolar state. What this means is that particularly if you have a very elevated level of glucose, the osmolality will be much higher than normal, and this will lead to osmotic shifts in fluid from the intracellular space to the extracellular space, which will effectively dilute the sodium and cause a hyponatremia, since the amount of sodium in the blood still remains the same. Because the fluid shifts occurring here are due to a hyperosmolar state and do not actually have a net increase in total body water, the patient is still euvolemic here, and this is different from hypervolemic hyponatremia, where there's actually an increase in total body water, which I'll discuss a bit later. And so to summarize, you can recognize a osmotic hyponatremia or a hyperosmolar hyponatremia when there is a markedly elevated glucose, and you can calculate a sodium level corrected for the glucose level using various formulas, such as the sodium correction being 0.4 times the glucose subtracted from normal, roughly 5.5 millimoles per liter, which is added to the measured glucose. Or you can use the CATS method, which is easier to remember, which is that the sodium will decrease by 0.3 millimoles per liter for every millimole of increase of glucose from baseline. It is important to recognize osmotic hyponatremia and to correct the sodium level when the glucose is markedly abnormal, because that calculated corrected sodium will tell you what is the true physiological sodium, so to speak, from which you should be basing your treatment decisions on. So as an example, let's say you found a patient has a sodium level of 128 but has a glucose level of 25.5. Using the formula mentioned, we have a sodium correction of 8, which is 0.4 times 20, which means the true physiological sodium is 136, which is 8 more than 128. And so at 136, the patient has a normal physiological sodium, which does not need any intervention, but presents with a osmotic hyponatremia of 128. Recognizing this will avoid intensive and unnecessary investigations and unnecessary treatment. The next entity is that of pseudohyponatraemia, which is an artificially low sodium level due to the measurement method. Many chemistry analyzers use an indirect ion-specific electrode method to determine the concentration of electrolytes like sodium. This involves a pre-dilution step prior to actual measurement with the electrode, and then this measured level is converted to a final reported level based on the degree of dilution. This dilution step is not an issue if the assumption holds true that the aqueous component of the plasma is 93% and the solid component is 7%, which is true in the vast majority of cases. However, if the patient has a markedly elevated solid phase, such as with very high levels of lipids or protein in the blood, which would make the solid phase more than 7%, then the water or aqueous phase will be less than 93% and can be substantially less. And so after dilution, there's actually proportionally less sodium in the diluted sample. And so the ion-specific electrode will measure a slightly less sodium activity and hence report a lower sodium concentration. And so you can see a pseudohyponatremia can arise if you use a indirect ion-specific electrode method to measure the sodium concentration in patients with markedly elevated lipids or protein, essentially an elevated solid phase in their plasma. You can check if the patient has pseudohyponatremia or not by doing lipid levels and to look at the total protein. If either of these are markedly elevated and the patient has a hyponatremia, then you would suspect that this is actually a pseudohyponatremia. Another way to tell and to circumvent this problem of getting pseudohyponatremia is to use a blood gas analyzer, which uses a direct ion-specific electrode method, which does not have a pre-dilution step and measures the concentration from whole blood. Because there is no pre-dilution and you're measuring the ionic activity from the whole blood, you can be sure that you're getting an accurate measurement of the physiological electrolyte concentration. Therefore, you can't get a pseudohyponatremia from a blood gas sample, and so in this instance, blood gas results should be considered to be more accurate than formal chemistry results. This is important to note because there's a common misconception that the formal chemistry results are more accurate than blood gas. Now that we've talked about osmotic and pseudohyponatremia, where the osmolality is usually high and normal respectively, we can go on to talk about hypoosmolar hyponatremia, which is true hyponatremia that needs to be further worked up and managed. It follows that once you see that the patient has a low sodium, the next thing to do is to look at the osmolality to see if the osmolality is also low. If it is, we can then try and distinguish which of the three main subtypes of hyponatremia the patient falls under, which we've previously mentioned, and we'll soon discuss in more detail. The two important tests we can use are the urine sodium and the urine osmolality, where the urine sodium essentially reflects the degree of renin-angiotensin-aldosterone system activation, such that in a hyperactivated state, the body will be trying to conserve sodium to conserve water, and hence urinary sodium excretion will be markedly reduced, less than 20 millimoles per liter. In contrast, the urine osmolality reflects the degree of antidiuretic hormone activation, such that when ADH is very active, the body will be in a state where it's trying to conserve water, and hence there will be a high degree of water reabsorption through the kidneys, and the urine will become very concentrated, leading to a high urine osmolality of more than 100 milliosmoles per kilogram. Using these tests give us clues of the degree of renin-angiotensin-aldosterone and antidiuretic hormone activation, and can help us clarify our differential diagnosis, which we'll now go on and discuss.